Up next, we have Dr. Peter. I don't want to be disrespectful by calling him by his first name, but that's how he has told me to refer to him. So he is, you can see it on his slide. He's pretty much an EMS doc. We have him come and speak at pretty much every conference that we have. He's an EMS physician, not an EMS physician technically, but he's an EM physician and a toxicologist, and a good one at that. And I think you run your medical director for a toxic a tox center, or
Yeah, so I run our poison center here in Kentucky.
poison control center. Yeah. All right, thank you.
Thank you. It's a pleasure to be here with all you guys and listen to some pretty great speakers. Hopefully I'm just going to go through some toxic EKGs, because EKGs are amongst the favorite for EMS and EM providers. We love to get them, look at the squiggly lines on the page and try and figure out what's going on. That's my pedigree right there, but really I'm an emergency physician and just a giant tox nerd to go with it. Got to review those objectives. So we'll start with just going over some basics for ECGs and some basic interpretation. And we're really going to delve into kind of our toxic effects on ECGs and what that means and what we can expect to see. So I think we're all familiar with what an electrocardiogram looks like. I remember when I was a child, my parents were physicians. I always wondered what the squiggly lines on the page meant. And eventually, about 20 years later, I finally got to learn what they mean and learn to interpret them. These are just the basics. I'm just using this here to go ahead and set up where we're going to be looking. So, our important areas and our important measurements are going to be our PR interval, our QRS complex, as well as that QT interval. The interpretation of an EKG is something similar, I think, that we all know and we repeat on a relatively frequent basis. Remember, rate, rhythm, axis, the intervals, whether they're elevations or depressions, any inversions that are important, and whether you note any U waves coming further out. So first one to pop up, of course, is our PR interval. This is, our area that's really going to show us some AV conduction time here, beginning at the P wave and ending right at the start of the QRS complex. Typical measurements we expect to see is, 120 to 200 milliseconds. Pediatric patients, we can expect that to extend out a little bit. And review a little bit of our toxicity here. So depending on how long that lengthens out, depends on the toxicity that we get. The definition of our first degree AV block is we've got to be greater than a 0.2 milliliters here. We can get our second and our third degree AV blocks, which, eventually lead to lack of conduction down into the ventricles. The medications we typically associate with this, simply put, if you start to see this in someone that has never had this diagnosis before, it's nice to ask about beta blockers and calcium channel blockers. I have listed here for us our more popular beta blockers and some of our more popular calcium channel blockers that are more likely to cause this. Sorry, I'm having real trouble getting my click wheel to not flip through two slides for me at a time here. The QRS complex is supremely important for the toxicologist. It's one of my favorite places to look for signs, and it's one of my favorite places to kind of question my residents and med students about what is going on. So this is going to be the area that shows us right to left depolarization of the ventricles, beginning at the Q wave and then kind of ending at the S wave or the J point. Typical measures are somewhere between 60 milliseconds to 100 milliseconds. Admittedly, you can probably go out to about 120 milliseconds, give or take, with it being considered by the cardiologist to be normal. One of the things for us as a toxicologist as a caveat is anything that is over 100 milliseconds is considered to be pathologic until proven otherwise. This is the benefit of having serial EKGs for your patient. Hopefully having one from 3 to 6 months prior or even a year prior can be helpful. In our toxicology, what are we really looking for? We're looking for abnormal duration or abnormal morphology. So duration, again, we're looking at something that's greater than 100 milliseconds in length. And then morphology is, for lack of a better term, the QRS complex looks funny. And we can look and get an idea that there might be something going on, especially in the setting of ingestion, if that QRS just looks funny. We'll sometimes see some abnormal axis changes. So they're up when they should be down, or they're down when they should be up, or sometimes they go back and forth, alternating up and down in our QRS complexes. That would fall into that category of, just kind of looks funny. So, and remembering that for the toxicologist, in not knowing that you have an abnormal QRS complex to begin with, 100 milliseconds is considered pathologic. We kind of start to see that bundle branch block there as we see delayed conduction through our His bundle and through the Purkinje fibers, and that's what causes us to get that widening all the way out to the J point. And what does it really matter? So on one side, I have a list of the medications that typically are going to cause this. QRS widening for me means that you have some sort of sodium channel dysfunction, typically sodium channel blockade. And the things that are big for me that are going to cause that, I'm looking at my TCAs, our old tricyclic antidepressants that disappeared for a little while, but are now making a great resurgence back for the treatment of migraine and sleep and some treatment-resistant depressions, as well as chronic pain syndromes and fibromyalgia. Propranolol is another big one that people sometimes forget about. One of our favorite beta blockers, and something to remember that it has this membrane stabilizing activity, otherwise known as sodium channel blockade as well. So in a propranolol overdose, what you may actually see is bradycardia, hypotension, and a very wide QRS. Our antihistamines, diphenhydramine in particular, seem to cause sodium channel blockade, which leads us to have this wide in QRS. And then even aspirin in severe overdose has some sodium channel blocking abilities. Other common things that you may see depending on the population that you have, cocaine can do this as well. And then the real big question is, why do we care? Why am I getting this EKG? Why do I even care about the QRS? And that's detailed over here on the right. What it comes down to is that if you have greater than 100 milliseconds in your QRS, and we consider that to be pathologic, you've got roughly about a 40% chance of having a seizure related to that overdose. And then if you get up to greater than 160 milliseconds, it seems uniform that everyone is going to have a seizure, and that your risk of developing a ventricular dysrhythmia goes up to 60%. And ventricular dysrhythmia being the ultimate cause of death for most of our overdoses, and in particular for those that are going to cause sodium channel blockade. The data for this all comes from, let's say, near the good old days of medicine, when, again, TCAs were decidedly more common, and we were trying to figure out how we can take care and predict and decide who's going to do well, who's not going to do well from a TCA overdose standpoint. So looking into the abnormal axis, we see what we call a bidirectional tachycardia. Really for us, this is something I have to remember when I take my boards, but really there's two reasons that you get bidirectional tachycardia. The one that most people just need to remember and know is digoxin. That's a digoxin overdose. Most likely this is bidirectional tachycardia. You can kind of make your diagnosis with that, although less commonly can also be seen as aconite. We got a good story for aconite. So when I was a fellow, I did my fellowship up in Oregon. On one of our first days of fellowship, there was an aconite overdose. I want to say that my senior fellow had the case, and the patient had been taking medications that had been labeled like Mung medicine number 9. And apparently she was supposed to be taking Mung medicine number 7 or Mung medicine number 4. And so she developed bidirectional tachycardia, and my senior fellow very appropriately said, I think that this is aconite toxicity. And our program director kind of made a face and he said, is there any aconite, huh? And I said, yeah, aconite, it's, wolfsbane, monk's hood, or aconite. Those are the three. There's other names for it. And, Rob kind of looked at me quizzically and said, are you sure? And I said, yes, of course, Rob, I'm sure. And he pulled out our Gold Frank's toxicology book and took a look and was like, there it is. Wolfsbane, monk's hood, aconite, they're all the same thing. And kind of looked up with a big smile on his face and said, oh, you've been studying before you started fellowship. And I had to confess to him, absolutely not. That was the first question that Snape asked Harry Potter when he showed up at Hogwarts. What is the difference between monk's hood, aconite, and wolfsbane? And that's the only reason I knew they were the same thing. A kind of wave of disappointment came over Rob, and he stayed that way for the 2 years that I was there until I graduated. So the bidirectional tachycardia can also come from some familial genetic disorders and things like that, but that's kind of beyond what we're going to have to worry about. And the last one is kind of this Brugada pattern that can sometimes occur. Typically, we associate that with another inborn kind of error of genetics related to the sodium channel as well. But it can be seen in different conditions, including something like hyperkalemia can cause this. Just a stock image from the internet of a bidirectional tachycardia, something that you can kind of remember. And here we have the Brugada pattern as well. So you can kind of see that awkward slope that comes through for sitting in V2 for our patient here. That's kind of pathognomonic for our Brugada pattern. And then the dreaded QT, QTC, my probably least favorite part of the EKG. Why? Because, you know, this is a combination of our ventricular depolarization plus our repolarization. So we're starting from the beginning of the Q wave and going all the way to the end of the T. Typical measures expect to see 360 milliseconds all the way up to 440, 450 milliseconds. Admittedly, when you look at it, it's probably, it's my least favorite part, because you can see that it includes the QRS. So, you know, as someone that's on the phone talking to people from the Poison Center, I'll ask, you know, how does their EKG look? And I'll ask, how does their QRS look? And they'll tell me their QRS is normal, and then give me some ridiculously large number for their QTC. I have to ask again, are you sure the QRS is normal? Are you sure the QT is normal? Because a lot of the widening that I can see is actually more related to QRS and sodium channel blockade than other causes. This is the fear, you know, our torsades are self-limiting rhythm, but our torsades is our big fear with as that QT continues to widen out. This is exactly what we don't want to see. So, you know, I care about the QT because I'm looking to predict whether torsades is going to occur, as well as maybe kind of as a surrogate measure to give me a little bit of an insight into what may be going on with the electrolytes. Maybe they're hypokalemic, maybe they're hypocalcemic, maybe they're hypomagnesemic, at least an idea of what I can kind of come to expect. I used to say when I was a medical student, when in doubt, when they would ask you about the side effects for a medication, the answer was always QT prolongation. And I've got in my years to continue on, I've found very little that doesn't agree with that. You know, the only things that I know that probably aren't going to do that are going to be calcium and magnesium. But, you know, simply put, almost nearly every drug can seem to cause QT interval prolongation. These are some of our more common ones that we see, or ones that are out there and forgotten, because we sometimes forget that sotalol also blocks potassium channels as well and can cause this QT prolongation. Zofran, which, you know, we use nearly as much as water in the emergency department. The fluoroquinolones, which we're definitely backing off on use for. Azithromycin is also now a big culprit, and then even amiodarone can cause QT interval lengthening. So what are our treatments when we look at the toxicities that we see? So for the PR interval, it's largely not a whole lot. As long as you don't, you know, have a malignant, you know, second degree or third degree block, we don't really worry that much about your first degree block. We just kind of tell you, hey, that's something you need to keep an eye on. Maybe we need to adjust the dosing on your beta blocker, your calcium channel blocker, or switch you to something else. But there's not largely a whole lot to do. The QRS toxicity, and the ones again we see from TCAs and propranolol, digoxin, or aconite, you know, our go-to is going to be sodium bicarbonate. So personally, for me, if I see QRS widening like that, especially in someone that's got an ingestion, you know, I like to grab an amp of bicarb all the way up to 3 amps of bicarb and get someone to run a continuous ECG for me, and then we'll push that IV and we'll look to see, does our QRS narrow? Is our QRS responsive to bicarbonate? Because that's fairly important to me, and it helps me to decide whether this is truly an ingestion or an ingestion-related QRS widening. You know, if bicarb doesn't work, you don't have access to bicarb because we're going on shortage or something like that, lidocaine and procainamide can be helpful as well in this area. With QT toxicity, for the most part, we don't have to do a whole lot here either. Mostly focusing on electrolyte replacement. You can make the argument that maybe using something like isoproterenol could be helpful because we're going to overdrive pace them here. You know, and we can give the large doses of mag, although admittedly, when you look kind of through the data, it's not that great about giving magnesium to narrow down to QT. We're just kind of more extrapolating from what we've done with torsades in the past. What is useful here is, again, using the QT nomogram. So what it really comes down to is they went back and kind of looked through all the case reports and everything else that they could find for patients developing torsades for when they actually had an ECG for them prior to that. And what it turns out is that if you lie below this line, you're probably much safer for developing torsades, and no one developed torsades in that group. If you were above that line, people develop torsades. You can take away a little bit that tachycardia is going to be a protective against torsades. Why? Because we have to narrow that QT to beat much faster. Let me take a little review. Let me see where my time is. Almost right on time. A little review, just kind of take a look at some of our basic ECGs and things that we can see. So for example, here's a normal ECG that we're all happy to see, and will come across your desk multiple times a day. Actually, I don't know the last time I saw one that was just completely normal. There's always some sort of abnormality that I have to sign off for. On this one, we're just looking at sinus tachycardia here. So something that we expect to see kind of with our sympathomimetics, or cocaine, or methamphetamine, or PCP, even ketamine people are using. Our serotonergic agents will cause this, as well as we're starting to develop serotonin toxicity, or the serotonin syndrome. TCA is well known to cause this as well. This is oftentimes the first sign that you've actually got some sort of sodium channel poisoning, is the development of the sinus tachycardia will be the first sign that we can see. Aspirin as well, but this is more kind of related to relative dehydration than anything else. So this one came from a TCA overdose. And the thing that's kind of important here is, one, we see this very tall R wave in AVR that's nearly pathognomonic here. Greater than 3 millimeter R wave in AVR is suggestive of TCA overdose. And then we get our widened QRS as well. So what are we going to do? We're going to give them sodium bicarbonate. We're going to watch it narrow. Is there any advantage to doing boluses versus doing a drip? No, not really. It's just kind of, how often are you going to look in on your patient? For the most part, we put people on drips, I think, because we feel safe and we feel that it's automated. But the other problem with drips is that then no one kind of pays attention to your patient to follow afterwards. You still need to at least come in and check on their telemetry and repeat their EKGs appropriately. This is just a junctional bradycardia here. Where do we see this? We can see this in our beta blocker overdoses, our calcium channel, and our clonidine overdoses. When you really begin to ask that question of, like, how do you differentiate between those three? If you're seeing something like this, it's the finger stick glucose and the physical exam that are going to really bear out. Clonidine overdoses kind of get this periodic apneustic breathing that we see it more commonly in children. When you're taking a test and you're thinking about textbooks and other things, hypoglycemia is what you should see for a beta blocker overdose. Seems that also really holds more true for children than it does for adults, but it's still something that shows up on test questions. The hyperglycemia in calcium channel blocker overdoses definitely does occur. So if you see hyperglycemia with bradycardia and hypotension, you can be pretty assured of your diagnosis, although admittedly it doesn't exclude like a diabetic patient that's on a beta blocker or a clonidine. So that's our bidirectional, biventricular tachycardia. So think digoxin, think aconite for these ones. Digifab is something that we can consider once you finally get to the hospital, but kind of in the EMS arena, thinking about IV fluids and lidocaine, and please call the poison center if you can. We're here to help. So that's a long QT. We can really see it when you point out the Q all the way out to the T. First blush, it doesn't look that bad, but when you finally start looking and asking questions, there it is. So in this one, this was a 78-year-old lady who had AFib on amiodarone, who took her Sotalol, and she's currently being treated for a UTI with Cipro, and she's nauseous. And so what happened, someone actually went ahead and gave her some Zofran, and boom, there it is. We got torsades. We got our big fear occurred. Got some magnesium and started overdrive basing with electricity, and she recovered fine. Turns out it can be relatively difficult to try and get isoproterenol, because nearly half the people that you're asking for don't know what it is, or have never used it. And it's just straight up VTAC, but we can use our lidocaine and procainamide to treat. And so this one, again, is something that, we may not pay that much attention to, but you get this slurring kind of down here going from S to T. And that looks like quite a bit like DIG. Something to be a little bit concerned about here. The rate is 48. They're bradycardic. They got the slurring of the ST segments. So it looks like it was most likely to be DIG. They always teach you, think about it as the Salvador Dali. And I always thought that this looked like his painting of the melting clocks. I was like, oh, that makes perfect sense. Melted clocks, it kind of looks like, this one in here and this one in here. And then finally, when I actually got to fellowship, it was pointed out to me that that is not what they're talking about. They are entirely talking about his mustache. And so if you can kind of see the appearance of his mustache here versus that DIG effect over here on the QRS, it's like, oh, okay, I guess that makes a little bit more sense, although I still like my way better. In summary, if you're thinking about things that are causing someone to be bradycardic and hypotensive, check a finger stick, see what's going on. If they're hyperglycemic, think calcium channel blockers. If they're hypoglycemic, think beta blockers. If they're really having respiratory issues, think about clonidine. If their ECG is just weird, or they're very old, or that they have a very old physician, think about the digoxin as well. QRS widening here is going to be pathognomonic for a sodium channel blockade. So think about the antihistamines. Diphenhydramine in teenage girls is super common. TCAs and propranolol as well. Get that bidirectional tachycardia. That's digoxin or aconite until kind of proven otherwise. And then when in doubt, sorry for the folks in the UK, I know this isn't the most helpful one, but when in doubt, if you're here in the US, go ahead and give us a call at the Poison Center. We're available 24 hours a day, 7 days a week. And thank you for your time.
Thanks, Doc. I don't think I waited long enough after the last speaker finished to see if anybody had any questions. I apologize. Do you all have any questions for Peter? While they're thinking of questions, I do have one. So for TCA overdose, we keep a limited supply of sodium bicarbonate on the ambulance. You mentioned giving lidocaine. I find that interesting, considering that lidocaine is a sodium channel blocker, and TCA overdoses poison the sodium channels. Why is that? Why does lidocaine work? And at what point would you consider giving lidocaine over sodium bicarb or switching to lidocaine?
So it all has to deal with where they're going to bind during the cycle of cardiac contractility. So we think about lidocaine as kind of fast on and fast off. And so what lidocaine will do is it will outcompete essentially the TCA at that receptor. So lidocaine swoops in, your TCA is not able to bind into the receptor, but in the same stroke, lidocaine sweeps out, and you're able to get relatively normal conduction kind of through that process. So that's the first time I heard that, and the first time I read that, I thought there's no way that that's actually accurate. That has to be crazy. But when you look through the data and you kind of look at it mechanistically, that works. When would I consider it? I used it most often when we were having our sodium bicarbonate shortages, and they were trying to convince us to switch to sodium acetate, which I just didn't seem to think was working very well. If you start to see their dysrhythmia, or that QRS continue to widen, or you see signs that you're going to get something like a malignant dysrhythmia, that I would be all for going ahead and pushing lidocaine at that point in time, and then seeing what response that you get. Sodium bicarb has its benefits and its downsides, and maybe with the sodium bicarbonate, there's also some suggestion that as you raise that pH and make it more basic, you can change the shape of that sodium channel. And with that shape change, that conformational change, and you don't get anything that will actually bind to that same site. To answer the question, lidocaine, it's the same as what you would use for your, it's simply put, you can start with just your cardiac dose for lidocaine, and that'll be just fine.
Excellent. Good explanation. One more question. I think you answered our attendee's question.
Peter, it's Walt. I have a question.
Yeah.
Hey, What the hell is aconite? I hope I'm not the only one that doesn't know that.
So it's a plant that grows around, typically used in like a lot of like Asian and South Asian cultures, but it actually does grow here in the United States as well. Typically in the US, we tend to call it like wolfsbane or monkshood. For the most part, we tend to avoid it and not ingest it. But because it is like a little bit of a sodium channel blocker, historically, people sometimes used it for palpitations and other things. Don't worry about aconite. Like, you only need to know aconite for when you want to hang out with the other tox nerds and someone says, what's going on with this bidirectional tachycardia? And, someone else will lob out from somewhere, oh, this is digoxin clearly. And you can be like, well, aconite is also in the differential. It's great for like, bar time and parlor tricks when you want to impress someone.
Oh, I am worried about it, and I'm working this weekend. It is going to go on somebody's chart. I don't know who it is yet.
Outstanding.
All right.
There is a question. I have seen QT toxicity in people with overexertion for certain, especially those with eating disorders. I typically attribute that to, poor nutrition prior to their workout, as well as kind of the changes in electrolytes that are going to occur from sweating and not appropriate hydration during these, long advanced runs and whatnot.
All right.
All right. Thank you very much, y'all.